In this session, I'll discuss a case which we have done with antegrade dissection and re-entry after failed antegrade wire escalation in an RCA CTO with a chronic kidney disease. Coming to the history of the case, this guy is a 70-year-old male with ischemic heart disease, old anterior MI, a severe LV dysfunction, admitted with decompensated failure. With medical therapy, he went into a compensated failure, and he was a smoker. He's hypertensive, non-diabetic, and he developed contrast-induced nephropathy after coronary angiogram done outside. Serum creatinine jumped from 1.2 to 2.1. This is the angiogram of the patient, which showed total occlusion of RCA. You can see there is a total occlusion with a possible, one microchannel which is filling distal RCA, but the disease was quite long segment. Though RCA is filling here, so it's good vessel is visible only at the bifurcation of RCA. This is the left system showing total occlusion of proximal LAD. Proximal LAD is completely occluded. There is one septal which is filling probably PDA, and diagonals are LCX, and diagonals are giving collaterals to PLVB branches. Okay. So we did a viability study. So because there are CTOs in RCA and LAD, and LAD distal vessel is not visible, wherever the distal vessel is not visible, so there comes a question of viability. So we did a cardiac viability, so which showed no viable LAD territory, and in RCA territory there is a good amount of viability. So this is an echo. You can see thinned out anterior wall, and inferior wall is quite mobile, only with slight increase in echogenicity. So as our LAD is not viable, we decided to go ahead with revascularization of RCA and PCI as a strategy. So when I looked at JCTO score of this patient, so you can see there is proximal cap is clear, it's not blunt, and there is some microchannel with a possible connection to distal lumen, and there is a good filling of RCA here, and and after PDA RCA is visible, so from bifurcation downstream. If you see, there is one collateral from septal artery which is filling PDA, not well visible, but there is one small collateral. So there is no we can say JCTO score except length, occlusion length, rest all are almost negative, nothing was visible. So we can say JCTO score is 1. So only the length of the lesion is quite significant. So coming to the hybrid algorithm approach of wiring strategy for this CTO. So I thought there is a microchannel, so I decided to go ahead with antegrade. But there are a couple of challenges in this case. One is like contrast load. So more important because patient had a CKD and he also had a jump in serum creatinine after having angiogram. So we have to, whatever wiring strategy we decide based on minimizing even contrast load. So I went ahead with antegrade. So planned antegrade, and if antegrade fails, probably we can switch to ADR or retrograde strategy. So this was the basic plan, and for retrograde there is a septal collateral coming from first septal, But the only problem is it's almost like brook-like septal. So there are multiple branches coming out of this septal, so which mandates multiple contrast injections, for entry quite often. So yeah, these were the issues. So LV function and his renal function, so which we have to keep in mind while deciding wiring strategy. I went ahead with antegrade wire escalation with a Caravel catheter. So first wire I used slip through wire, that is fielder X3, but I couldn't cross lesion. So we entered only 2 to 3 millimeter into lesion, but after that it couldn't advance. That's why I changed wire to penetration wire with the direction control, that is Gaia 2, and Gaia 2 could be advanced across the primary lesion, but subsequent injection showed Gaia 2 is in subintimal codes. We can see here this is the vessel, but Gaia 2 is in the subintimal location. So we can see in the orthogonal plane, this is the vessel and this is where Gaia is. So it's in a subintimal plane. So then I adapted parallel wire technique. So again in parallel wire, the second wire also went subintimally. We can see in orthogonal view, so which shows second wire is also in a subintimal plane. But what parallel wire demands is, so we need multiple injections in parallel wire to locate your wire distally in relation to true lumen. So, but this patient, we have to give complete procedure with low contrast. So that is the reason I switched immediately to the next strategy rather than giving more contrast in parallel wire technique. So what could be the best next strategy? So is it a retrograde or antegrade dissection re-entry? These are the only two options I have. So I decided to go ahead with the ADR than retrograde, mainly because of contrast limitations. See, in this patient, there is a good retrograde channel. I feel it is around CC2, but it's almost like, there are multiple branches coming out of this septal. So in such a cases where septal has multiple branches, so we end up in giving multiple injections to confirm wire position in septal, appropriate septal. So keeping that in my mind, so I thought of going ahead with ADR, because ADR is quite predictable and it won't demand much contrast usage. So what is the ADR plan for this case? So this is a proximal cap, and I have to choose a distal re-entry zone. So we have two areas where we can re-enter. This is one area in the mid of RCA where the lumen is quite visible, but after that again we are not able to see lumen here, and again we can see lumen here, that is immediately before bifurcation. So obviously my area of re-entry should be before bifurcation and from where the vessel is quite well visible. So I thought I'll take this point for re-entry, that is before RCA bifurcating into PDA and PLVB. So this is my re-entry zone. So I went ahead with my ADR plan. So this is the cross bars. So as the lesion was very tough, so I thought of knuckling here to guide crossbars into lesion. You can see while I am trying to knuckle, crossbars is jumping into the side branch. So this is the tendency of crossbars, it tend to go to side branches. So then I decided, another problem if I knuckle here is you will tend to create good intramural hematoma. So that's why immediately I switched it to another wire, that is a fielder wire, and again I crossed with fielder wire down into the lesion. Then I sent a 1 mm balloon. So size of the crossbars is 1 mm. So 1 mm balloon dilatation usually is enough to advance the crossbars into lesion. So I dilated with a 1 mm balloon, and then we can see I advanced crossbars into lesion. So we created a space which is sufficient enough for crossbars, and that will occlude the lumen so that it prevents intramural hematoma formation. So now the crossbars is entered into the lesion. Then I advanced crossbars. So and crossbars got advanced and stuck here at this point. From this point it was not getting advanced. So then I pulled crossbars back into the middle of the lesion here, so you can see, and then I took a knuckle. So probable cause of stuck crossbars here is mostly some calcium sitting in the wall. So I pulled crossbars back and I used a knuckle wire with Fielder XT wire. So and I advanced knuckle beyond the zone where I was stuck. So we shouldn't knuckle till distal end. So knuckle should cross the point where crossbars is stuck. I mean, that is a limitation. So otherwise you will end up in an extensive knuckling. So I just crossed this point, this could be the calcium. So crossed that point, and then I advanced my crossbars over the knuckle beyond that point. You can see crossbars cross that point, and then you remove the knuckle and advance your crossbars by rotation. So you can see it is easily getting advanced, and then I reached distal re-entry zone. So you can see here crossbars always tend to push the vessel laterally. So, and sometimes you may feel as if crossbars and vessel are not in the same direction, but which was not true. This is because of the straightening of the vessel by crossbars. So yeah, you can see here crossbars reached my distal landing zone. This is a re-entry zone, and this is a crossbars in subintimal area. You can see in another view, that's a cranial view. So this is a crossbars, this is a bifurcation, and PLVB, PDA, and we can re-enter here into this is a lumen. So once I reached this landing zone, so I exchanged crossbars to stingray balloon with a miracle wire, miracle tool. So once stingray is positioned at re-entry zone, so now the important thing is you have to choose a view where you have to manipulate stingray wire into true lumen. So the ideal view is, so you have to identify based on these wings of stingray. So you can see in this view the two wings of stingray are visible very well. So we have to take a view where you don't see two wings of stingray. So you see an end-phase view of wings. So this is a view. You can see, you can't see the two wings here. So it's kind of end-phase view of wings. This is the view where we have to identify the location of the vessel. Actually here the vessel was here. So identify the location of the vessel, and then you re-enter with your wire. So you have, in this view, stingray has 2 points. One is one hole which guides your wire upward, and another hole downward. As the vessel is here, so you have to guide the wire towards up. So now you can see, yeah, you can see this is a view where your crossbars is seen in the subintimal space with the vessel above it, and you can see in the same view you can see the stingray wire. So I am entering through the hole upward and I am just coming out. So we entered with stingray wire and we came back while rotating stingray wire, and once this entry is created, then we can send a pilot. This is a pilot wire, pilot 150. So I have advanced pilot 150 wire, so without any difficulty into the PDA. You can see now the pilot wire is in PDA. So we re-entered into PDA. So yeah, I mean, I'll just consolidate the technique which I have used in this case. So first step what we did is we entered with the wire here, this zone, and we dilated with a 1 mm balloon just to advance the crossbars into lesion. Next I advanced crossbars, so entire this region, and crossbars was stuck here. And then so we used knuckle wire to advance crossbars. As a crossbars is stuck here, so I used a knuckle to cross this point, and again advanced crossbars, and then we advanced crossbars to the landing zone. So this is the crossing strategy which I used in this case. So once wire is into PDA, then I exchanged that wire with the workhorse wire using Caravel, and then I dilated the entire track with a 2 mm balloon. Then I did an IVUS to identify entry of PLVB, and then I used W-man catheter to enter PLVB. You can see this is a PLVB, and once it entered into PLVB, I dilated into PLVB, and then we did IVUS from PDA as well as PLVB. So just to show the difference of how this ADR crossbar stingray ADR strategy creates a very small subintimal lumen versus the knuckle. So you can see here we are coming from PDA. So slowly this is a PLVB which is joining PDA. Now you can see there is only one lumen, true lumen, but slowly now you can see here, this is the portion where I kept stingray balloon. So this is the dissection created by stingray balloon inflation. But still your wire is in true lumen, because the distal part of stingray balloon we entered through the proximal part. So the distal part of stingray balloon lumen which was created still is outside our wiring. So as I come proximally, now you can see the IVUS catheter moves from true lumen into false lumen. So now IVUS catheter is completely in the false lumen. So yeah, this is the point where I entered. See, now IVUS catheter is in true lumen. So this is the point where I entered from false lumen to true lumen. Now you can see, yeah, this is the true lumen which is compressed, and IVUS catheter is in false lumen. But if you see knuckle, so the kind of lumen it creates a wide lumen. You can see wide lumen in the vessel. And if you see, this is the point where exactly the crossbars was stuck because of the calcium, and this is a point where we knuckled. So you can see in angiogram also, the lumen created by knuckling is very irregular and very wide, but the lumen created in crossbars zone is very clear and appears as if like a lumen of vessel. So that is the difference between ADR with crossbars versus knuckling. So then we stunted the vessel with 2.75 into PLVB with 2.7538 and 3 by 38 and then 3.5 by 18. So, and this is a final angiogram which showed clear vessel and well flowing vessel. We can see the IVUS. So this is a distal reference which is 4.5, and this is a stunt in PL 6.1, and this is 9.4, 9.1, so 8.6, 9.8. So we achieved good stunt areas throughout the vessel. And if you see the difference between knuckling and crossbars, you can see here, see the point where we knuckled, there you will see malapposition of the shunt struts also. You can see here, see these are the shunt struts, but this is still the lumen, I mean the false lumen which we created. So that's what exactly happens. You will see good amount of malapposition in knuckled area, but if you see the area crossed with crossbars, you don't see such a malapposition. So this clearly says, we have to limit knuckling to the zone where you are exactly stuck. So never extend knuckle for a significant duration. So learning points from this case are: failed antegrade wire escalation with a good distal target, ADR is a nice option. Parallel wire may need good contrast injection to locate the wire positions to guide operator navigation. A quick switch off strategy in such cases is the key for procedural and clinical success. When you have contrast limitation, ADR adds value as course is quite predictable, and so is the need for contrast. If you have a good collateral without much side branches in the septal, that also adds value. So the need of contrast injections is lessened. But if there is a septal with multiple branching points, then you need a good amount of contrast for confirming your wire position. Crossbars prefers tracking lateral wall and coursing into side branches, which should be kept in mind while advancing it. Limited knuckling can be used if crossbars is stuck for some reason. Most often it's a calcium in the wall. Knuckling inside lesions avoids intramural hematoma, but knuckling from proximal cap may cause intramural hematoma. As we did in this case, we knuckled inside the lesion and avoided knuckling at the proximal cap. Knuckling may leave malapposition of shunt struts due to wider space created compared to crossbars. Thank you.